Well, welcome to another episode of the Addy Hour, our 20th episode, which I'm very grateful about. We've been doing this since about February of this year, so it's really been nice to see this come to fruition in a lot of ways. Today, I'm honored to be able to host another conversation on a really important topic. We're going to be talking about depression, ketamine, and just important considerations about navigating the mental health care system. So as usual on this podcast, some really important, some heavy topics, but it's also going to be encouraging, I think, as well, just as we talk through some of these experiences from our two guests, both from a provider standpoint and from someone who's walked through the system, and they're actually working together as colleagues in this moment as well. So I'll let them elaborate on that as we go through. But I'm honored to be able to welcome two guests to the podcast today. The first of which is Dr. Gerard Sanacora. Dr. Sanacora is the Gross Professor of Psychiatry at the Yale School of Medicine. He's also the director of the Yale Depression Research Program and the co-director of the Interventional Psychiatry Program at Yale New Haven Hospital. He's someone who's been engaged in research for over 25 years, using both preclinical rodent models and also human clinical studies to really understand the biology of neuropsychiatric illnesses, and also to really think about and develop new approaches for treating and preventing those illnesses in the first place. He's someone who's led a lot of different projects within the National Institutes of Health, projects that have been sponsored by foundations, projects that have been sponsored within industry, so has a lot of experiences in different realms. And what is really impressive is that he's also worked on creating and disseminating educational resources and also providing leadership to both national and international consensus on international consensus statements. He's won numerous awards for his work. He's a fellow of the American College of Neuropsychopharmacology. He also received the Anna Mankia Stiff Tongue International Award and received a Joel Eccles Research Award. So I'm grateful for the work that he does in this space and honored to welcome Dr. Gerard Sanacora to the Addy Hour podcast.
Thank you, Nick. It's really a pleasure to be here.
Thanks so much for being here. My second guest is Ashley Clayton. And Ashely is someone who describes herself as a person who loves stories, is an avid reader of poetry, memoirs, and nonfiction. She also finds joy and comfort in music, and impressively during the pandemic has picked up and has been teaching herself the banjo. Ashely is someone who grew up in the rolling hills of Kentucky, moved to Connecticut for grad school, and has been living in Connecticut for the past 12 years. She has a master's degree in community psychology and is also a research associate in the Department of Psychiatry at the Yale School of Medicine. She initially ventured into the community psychology space through a determination to use her firsthand experience with mental illness for the greater good, and she's also very dedicated to social justice. So she's a mental health activist. She's also published numerous research papers on social inclusion of individuals living with severe mental illness, on maternal mental health, on recovery-oriented and person-centered care, and has also written healthcare narratives and essays. She's on the advisory board of different organizations, also owns a consulting business where she provides consultation in program evaluation and patient engagement. So I'm deeply grateful for all the important work that she does, and also thankful that she's taken time to join us here on the Addy Hour podcast.
Yeah, thank you so much for having me. I'm looking forward to our conversation.
Definitely looking forward to it, and grateful to both of you. This, in some senses, is an in-house conversation since we're all at Yale. But also, we want to make sure, as we always do on this podcast, that we're just communicating to the general public as well. And so I'm grateful for the ways you all have done that already. And I know that this conversation is going to continue to do that as well. But as I always do on the podcast, I always like to check in and see how people are doing overall, especially as we wrap up 2020, as we look forward to 2021. And Ashely, why don't we go ahead and start with you and just see how you're doing in this moment?
Yeah, I think the most honest answer to that is I am both okay and very much not okay. So I think, we're coming into this, 2 years of a pandemic, and I think we're all sharing that stress. There's a low level or sometimes a high level of just general overwhelm, stress, fatigue. So definitely, feeling that. I think my life during the pandemic personally has been challenging, aside from, kind of everything we're all experiencing together. The day that Connecticut shut down, my brother, they found a second tumor. He had a glioblastoma. So kind of at the exact moment that everything, happened, our world, my family life, got pretty chaotic. And so he died earlier this year. And that's been, very painful and sad. So I've been in also, a process of mourning and grieving, but also being away from my family, not being there as much as I want to be. In 2020, I had 3 job transitions, which, is stressful. I've had some pretty strange health issues, physical health issues. So dealing with those, but I also feel okay in some weird way. So I think the most honest answer is really, I'm okay and not okay. And I think a lot of people can relate to that.
Yeah. I think that's such an important piece to just get across. I mean, just the level of candor that you just shared as well with everything that you've gone through in the last 2 years. And the fact that you can have both of those simultaneously, being okay and not okay. I think in a lot of ways, and people have heard this on this program before, but that's validating, I think, for a lot of people to hear, because sometimes I think people feel stuck in one or the other, like either I have to not be doing well, or I can, like, people don't always have room to have both. And I think that's really important and honest that you're sharing that. So really appreciate that. Jerry, what about you? How are you doing in this moment?
I think Ashley captured it extremely concisely, very well in many ways. And it's been professionally, it's been a hard year. As you can imagine, it's been extremely busy and trying to adapt to working in environments that we're not prepared to work in, doing so much by telemedicine. And a lot of the treatments we give are actually hands-on, and trying to figure out how to do that when the volumes are so high, but yet all the procedures that we need to ensure safety become so much more time consuming. It's been a struggle, but overall, I have to consider myself one of the real lucky people that has not been directly personally affected by this pandemic. And that has been extremely fortunate. And, the burden has not been shared evenly from everybody. That's it.
Yeah, that's very true as well. And again, similar to Ashley, I just appreciate the way you shared that honestly, because I think sometimes as well, and that's also come up, that people who haven't been directly affected sometimes lessen the challenges they've also faced. So, I mean, for you as a provider, obviously that's also very challenging. But at the same time, as you mentioned, you do have a place of thankfulness, being blessed and privileged to not have been directly affected. So I appreciate you putting that in context as well. And again, even as we're starting, that's one of the reasons why I was so grateful that both of you have joined. Just the level of candor with which you both speak, and the honesty and the realness, I think, goes a very, very long way. Another question which I wanted to ask, I mean, I allude to this in the introduction, but you all have had a shift in your relationship over the years. But I also just wanted to start and ask how the two of you met, in what context, and how that relationship has changed and developed over the years. So whoever wants to, I don't know the best person to ask to introduce that, but I'll let you all decide, I suppose.
Sure. Is it okay if I go?
Oh yeah, definitely.
Please do.
All right. So I met Jerry in early part of 2016. So I was hanging out with a colleague, our mutual colleague. Well, we're all colleagues, so of ours. And I had really, at this point, been struggling really severely with depression for the last few years, but it was the first time I was actually having what we call like functional impairments. I was having some cognitive deficits, struggling at work. I mean, I would just like look at my spreadsheet and be like, I don't know what to do. And so actually was on a partial medical leave from work, which was the first time I ever needed to do that. And so I had reached out to a colleague who does some research with ketamine in a different area than depression, and just said, hey, I remember you saying something about ketamine and depression. Could you meet and talk? And so he actually referred me to Jerry, who at the time was running a phase 2 clinical trial. And so he made a call on my behalf. Later that week, I met with Jerry to really talk about what his research projects, and to see, am I a good candidate for any of the studies he has going on? And is it something that if I am, I would want to move forward with? And so that's really, how we met first, and, kind of a principal investigator, physician, patient, research participant relationship. And I did end up participating in some clinical trials, and throughout that year. And, he was involved after the studies ended in the transition of my care kind of over to a team I have now. But I would, in the last few years, we've really established our relationship as colleagues, as people who really want to talk publicly and have good conversations about what is it like to, live with severe depression, what treatments are available, all of these different things together. That's a path I think we agreed we wanted to do. So we've kind of separated our doctor-patient relationship really and have established a firm relationship as colleagues here in the university. So
yeah. I look at it from the perspective, there are many good doctors that could do what I was doing to help Ashely, but there are very few people like Ashely that could really help us understand better how to provide the best care we can to patients. And I think our collaboration through this sense is real important. And I know you do have good care elsewhere. So that there are more good doctors than there are people like you. So
thank you.
Wow. Yeah, it's really powerful, I think, in a lot of ways. And just to be able to have, I'm speculating here, but I would say that kind of relationship is rare, to have that collegial relationship, and then people who are mutually invested and willing to learn from each perspective as well. And I think, that goes, we'll get into this as well, but that probably goes a long way into helping both sides see blind spots that we might not have seen otherwise, which I think is really important. I did want to pick up actually on one aspect that you mentioned too, in terms of, walking through severe depression, because I think that's a conversation that's really important that has talked about in society, has come up in this podcast as well. But I think sometimes from a general perspective, there's a lack of clarity on what people mean when they say, okay, I'm feeling depressed versus clinical depression versus severe depression. And so how, as you both have talked about this in public settings, how do you usually help people understand what those phrases mean and what the distinctions are? Actually, I guess we can start with you and then maybe go to Jerry from there.
Sure. Yeah. So I think there is a conflation of poverty, of depression and sadness, that they are one and the same, that when I'm feeling sad or down about something, that I'm depressed. We use that term, very flippantly and often. And I think that is not true. I also think clinical depression can look really different for different people, because you can have what I like to call like a constellation of symptoms. And so someone's clinical depression, even if we're categorizing as clinical depression, can look really different than someone else's. So I think it's important to talk about, and I'll just speak mostly to my experience, and I'll let Jerry do all the, from a clinical perspective, these are kind of the lines that we draw or what we mean or what is meaningful. But I often refer to what I am living with as severe depression, or, really difficult to treat depression. And I think for me, if you think about like depression as a spectrum, and you have this like, things aren't feeling right. I'm feeling down. I'm feeling fatigued. Maybe I'm not sleeping. I'm feeling restless, and there's a whole spectrum of where that goes to like where I feel like my depression, when it's not treated or well managed, goes real fast, which is this like overwhelming fatigue that my bones feel like they are hollow but made of iron. Like there's like nothing in them. It's an empty feeling, but it's a heavy feeling. I often feel like there's just like someone sitting on my chest, and I have to work to breathe. Not in the same way like if I'm panicked and I'm struggling to breathe, but if just like it feels laborsome. There's also, I tend to have like a loss of affect of like, I'm a person, I feel things really deeply. I'm a deep thinker. I'm introspective. And like, I will know all these things intellectually, but I will look at my husband and I might not have any feelings toward him. And that's really painful to experience. And I think for me in particular, and one thing I probably don't do a good enough job of saying, because to me, they go together so well, but it's not true, is my depression is often accompanied by pretty intense suicidal ideation. Mm-hmm. And that's not true for everyone. Even people who have severe depression might not have suicidal ideation, but mine tend to be pretty close one and the same. Mm-hmm. And so, before I, met Jerry and before I was in the studies, and I was walking around for 4 years, and every single day, and it got progressively worse. And by the time I met Jerry, like every single minute, like all I was thinking about is like how much I wanted to die and like what a burden that is to carry, and just how paralyzing that can be. And I think depending on the constellation of symptoms I have as an adult, I didn't, when I was younger, have what I refer to as kind of these functional impairments. But I have trouble seeing the future, thinking past. Sometimes I can't even think past a day. Sometimes I can't even think past an hour, which makes it really hard to problem solve and tolerate and do anything. So I think there's a range there. But for me personally, in my experience, that's kind of what I mean when I talk about it.
Yeah, I think that's really helpful, just the way that you've painted that picture, and even the bravery in sharing that as well, because I'm imagining people who've walked through that themselves, hearing someone else talk about it, how helpful and validating that can be. And for those who have friends and loved ones who don't always know how to respond or how to react to it, just hearing that personal perspective, I think is so helpful in terms of context. And really appreciate the way that you've painted that, and also just clarified some of the distinctions as well, because you're right, we do use it flippantly, not intentionally, but it really is important to have that distinction so people can really understand the differences as well. Go ahead, Ashley. Yeah.
I was just going to say, the one thing that I think I also think about is we often think of like happiness as the opposite of depression. And like happiness might, I'm not convinced, but might be the opposite of sadness, which is not depression. But Andrew Solomon said it, and he was like, the opposite of depression isn't happiness. The opposite of depression is vitality. I feel like that, like I was like, yes, like those things feel true.
That's really good. It actually reminds me of what you said at the onset too, just that you can be okay and not okay at the same time. Yeah. And that can be a good place to be. It can also be a challenging place to be. And there's not one static response to that, but even that in itself doesn't convey that, a sense of happiness all the time, which I think sometimes, like you said, people are looking for, but that's just not the reality of successfully navigating mental health in general. So really appreciate that as well. Jerry, anything that you want to add there, even in terms of big pictures? Ashley's painted that picture for us.
Yeah, actually, I'd pick up on a few things that Ashley said, but I think psychiatry in general is really plagued by having a lexicon that overlaps so much with lay language, and these words like feeling depressed and sad get used interchangeably where they really aren't. Sadness is a symptom of depression. And we use a lot of words in psychiatry in our common conversations that we have a different clinical meaning when we're really being specific about it. But I think the other issue that Ashley touched upon, which is so critical, is depression is truly, it's what we call a waste paper basket diagnosis, meaning it's a diagnosis of exclusion. So you have these set of symptoms and signs, and we can't find a reason for them. If we find a reason for them, you don't have depression. If you have hypothyroidism, you have hypothyroidism. If you're early stage Parkinson's, you have Parkinson's. You don't. So depression, by definition, is something we can't really identify. We don't have a positive test for depression. We have symptoms, and we rule out all the other alternatives. And if we can't find anything, we're left with the diagnosis of depression. And that alone, as you could imagine, makes it a very heterogeneous disorder. I mean, there are probably many different ways you can get to that endpoint of having those signs and symptoms. So it makes it very difficult. And again, following with what Ashley was saying, it isn't a sort of dichotomous thing where you're depressed or not depressed. In fact, most people don't fit that thing. It's on a continuum of how far. And not only just on a continuum, it's probably not a single axis. So it probably is not happy to sad. In fact, we know neurobiologically, it's not the same brain regions that control things like reward and control things like anxiety. There's actually different brain regions that are involved. And there's no reason to think that, this is on a slide rule that you just go from one to the other. There's probably multiple different axes involved in the way you're feeling. So very long-winded way of saying it's complicated and complex. I really, for me, it boils down to the functional impact on somebody's life and the quality of life. And those two big issues, determining whether it needs to be treated. How it needs to be treated is a very individualistic type, model to approach.
Yeah, I definitely, appreciate that context as well. And especially the functionality, because I think, for many of us who are mental health advocates, that's something we often talk about, whether people notice a significant change that's impairing kind of day-to-day functioning or day-to-day activities, or there's a big shift from people's normal kind of interactions in the world. But then I was also curious, what you mentioned about the exclusion piece. And for either of you, I'm curious, does that ever become a point of frustration for patients? Because I can imagine somebody saying, well, you're just ruling out everything else and saying, so it must be depression. And that, as a patient, I can imagine that would feel very frustrating in itself too. Are you sure it is, or what's underlying, and just kind of a feeling of unknown? Well, it's just this because we can't find anything else. Like how do those conversations?
I promise you, as a clinician and as a scientist, it's very frustrating too. I think it's, it's humbling. And I approach this by saying, I let people know that just because we don't know exactly what it is doesn't mean we don't know how to provide treatment, and we don't know how to make things better. We can know that without knowing exactly what's going on neurobiologically or having the perfect diagnoses. To take it to the extreme, I always remind people that, Newton isn't completely right in classical physics, but it's still enough where you can build the Empire State Building and have it stand for hundreds of years. So, we can have enough of an understanding to understand how to treat these, but we really don't know the underlying neurobiology for depression. And it's something I know you're working hard at. Our lab is working hard at. I think we're getting closer year by year, but we're not there yet.
Ashley, anything that you wanted to add on that point, both either as an activist or as someone, walking through and navigating mental illness over the years?
Yeah. So, I would say, it sounds terrible, but you're lucky if you find a doctor who's also going to look for other things and not assume it's depression, right? Where there might be the rule out if we've looked for all these other things. But I think depending on what kind of care you have access to, and maybe even where you live in the country, and maybe who that first doctor is that you encounter, they may or may not look for other things. I've struggled with some form of mental illness pretty much since I was in I would say at least middle school, if not sooner. I had a pretty traumatic childhood and had a lot of, symptoms of PTSD and, started self-harming when I was very young. And so I didn't have, I don't have the same kind of entrance story as some people who might become, depressed as an adult, or might have their first, kind of onset or episode kind of later of like, it was pretty smack in my face, like something's really terribly wrong. And so I was connected with care at a pretty young age. And so, I've been fortunate that I've had continued access to care, that, my parents had good health insurance, that I was able to go to good hospitals. I was in and out of hospitals, and, had pretty good team, for a while. And I would say, definitely depression there, but they're all arbitrary lines, but, was mostly really kind of post-traumatic stress and reactions to being in like some pretty not great situations. And I've been really fortunate that I've had a lot of therapy for that. And some time has passed where, that although, is still there and still comes up and bubbles up from time to time really isn't something that kind of interferes with my daily life in a way. But as an adult, kind of as that subsided, I think there was a process where I think depression really kind of set in and took over, and has been the thing that I think has been a continuous struggle for me for the last 10 years. So for me, it was a little clearer.
Right.
I do also have an autoimmune disorder, and I think we have just discovered that I have a primary immune deficiency. And I know you had a guest who was talking about that. And hopefully has a much more severe case than I do. But as a patient who fatigue is something I really struggle with, and it's a symptom of depression, and it's a symptom of an autoimmune disorder. And then, kind of just in the last 3 months, have found out, I have these other deficiencies that, like, when those are fixed, maybe I'll have some energy. So I also get the frustration of, like, my psychiatrist being like, it's your autoimmune disorder. And my rheumatologist being like, it's your depression. And we're all just like, and I'm like, I don't care, but someone please fix it.
Yeah, exactly.
So I appreciate that part too. So.
Yeah. Go ahead, Jerry.
No, I do. I just want to make sure that the point I made previously, and following up on what Ashley said, is clear. I think we need to be honest and be clear that we don't know the real underlying neurobiology, but that shouldn't be taken to mean that we don't know what to do, and how to treat and help people.
Right.
So, and as Ashley's saying, what we call it is actually less important than knowing how to have treatments that are effective. And Ashley's right. We're right on the cusp of understanding the role that neuroinflammation or neuroinflammatory disease could have, or immune deficiency in these disorders. And as I said, we don't really know the cause. And hopefully someday we can say nobody has depression because we can identify what it is and then treat it. But as it is, we're pretty good about treating the general diagnosis as it stands today. Right. We could be better, and we're getting better, but as it is, we're pretty good.
Yeah. Well, that's definitely well taken as well. And even, not always knowing the reason, but at least being able to move forward in the treatment phase as well. On that note, I also wanted to pick up on something that Ashley mentioned as well, just in terms of, having providers who were in that mindset and trying to make sure that they treated the depression. And and this, in a sense, is a little bit bigger than the depression topic itself, but just mental health in general, as we've also talked about on this podcast, just not only access to care, but how providers react to people from different backgrounds and the aspects of how race plays in, racism or zip code, and whether that is uniformly accessible across the board. But even say getting past that level, saying that it is accessible, let's make that assumption, even though we know that's not true universally. But even once that is provided, Ashley, you've talked a lot about just navigating the system as well, and the ups and downs that you had in that process. So thinking about your 2019 piece, My Struggle to Access Life-Saving Mental Health Care, I was wondering if you could actually just take us through, as we move to that topic, how you went about putting that piece together. What was that process like for you?
Sure. Yeah. Of writing the article, or
writing the article, and what motivated you to actually put it out there?
Yeah, sure. So, to get people up to speed, if you haven't read the piece, but like I said, I met Jerry, I was in some clinical trials because unfortunately I was like one of those people who we didn't know really how to treat my depression. I had a very good doctor, and I'm what I like to consider a very good patient of, like, I'm willing to try things. And if I'm not, I'm going to tell you and we'll get a better plan. But I'm willing to hang in there and see. Right. And so, we had been trying for, at this point, 2 years, different combinations of medicines, like different classes of medicines, all sorts of things. I was running, I was doing yoga, I was behaviorally doing everything I should be doing. I was in therapy. I switched to another kind of therapy, and I was getting worse. So by the time I, found Jerry, I think everyone was just like, I don't know what to do. And I was lucky that I did respond really well to ketamine, and we can talk about that later, which is what I received in the clinical trial. But in that process of enrolling in a clinical trial, and you get access to this care that you can't get otherwise, right? It's still being studied. And, ketamine, because it is FDA approved for other reasons, like you can access it, unlike if it's a, experimental drug without any kind of approval. But then the question always is like, what do you do after? What do you do after the study ends? What do you do after the protocol ends? Protocols are different. Sometimes you have continued access. Sometimes it's a one and done thing. And so, we were in that situation of, oh my gosh, I found something. I responded super well to it. I can't get access to it otherwise. My insurance is going to pay for it. It's very, very expensive. There are very few people, who at that time were receiving it, ketamine on an off-label outpatient basis. And, I ended up in the hospital for over a month on full medical leave. I, tried electroconvulsive therapy because that is the gold standard, and that was the best option. We had really exhausted options. And unfortunately, I just didn't respond to that treatment. And so after that process, Jerry and some other physicians at Yale New Haven Hospital were able to get me into the program to be able to receive ketamine outside of a study setting, really to save my life. But it was, I'll let Jerry speak to it too. It was a terrible, terrible struggle where, it was a treatment by treatment approval by whoever the administrators are, and love you, thank you for doing that and saving my life. But really, it was somewhat out of the doctor's control, or quite out of the doctor's control. And it was particularly frustrating because I knew there was something that worked. It wasn't like I didn't have any hope. Right. Like I knew. I was like, if you can get me this, like I will live. And I think being that unwell and having to advocate for treatment, and I was exhausting the tiny resources I had left that I could have been using to try to replenish some internal resources to make the case or connect with the right person, or, I feel like I was willing to beg to be like, I will do anything because I'm going to die. And it was terrifying. And I was so lucky. And so I think once I got approval to receive this treatment for free, like on that day, like if it hadn't happened that day, I'd had a conversation with one of my doctors and just said, like, I don't think you guys understand how unwell I am. And like, it's going to be too late. Like if we don't fix this, like it's going to be too late. And had I walked out that day with a different answer, it certainly would have been too late. That's where I was. And I think, I quickly felt well after about a month of treatment, which was such a blessing from being so unwell. But I knew that like luck played a huge role in that. And that made me very, very unsettled and scared as a person. And I also recognized, like, of this situation, I am better situated than 99.5% of people to have negotiated this and gotten through it. I'm white, I'm well-educated, I'm very well-connected. I work in the Department of Psychiatry. Half of my friends are psychiatrists or psychologists. I've been in the system for a long time, so I know about the healthcare system. I research it. I just was so well equipped, and I almost died. And I was like, oh, this is what happens. Like this is how people fall through the cracks, and this is how people die, because not everyone is as well resourced and connected as I am. And so that was what motivated it, part. And part of it, it was selfish of like, I was terrified it was going to happen again. And I needed to have a better system because I knew that like, I will not get lucky twice. And I also knew like, I wouldn't, if I had to do it again, like I wouldn't survive. I still kind of believe that of like, it is remarkable that I survived, and I'm so thankful for that. But like, if I had to do it again, I'm still not sure I would.
Right.
And so I wrote this piece in part for me too, of like, yes, to help others and build a better system and try to think about things differently. But then also selfishly, I was like, I almost died, and I don't want that to happen again.
Yeah. I'm grateful that you're here. Grateful that you took the time to write that on so many levels. But at the same time, it's so sobering as well, just to hear how close that was, even with all the resources that you had access to. And I say that not in the sense that you had access to everything you needed, but comparatively, as you mentioned, to others who would not have those same resources. And even still.
And well, resources, but also like the best doctors, like the people who are at the top of the field, cutting edge everything. And then also who are just like very good humans. So it really was like the perfect situation to be in, except for it was a whole hot mess, because the system is very broken if there is a system.
And Jerry, go ahead. But I was going to just hear your perspective too, and your reactions, in those moments, and even as you and Ashley have continued to talk through this.
So there is, the aspect where the system, I don't even know if it's fair to say the system's broken. I'm not quite sure it was ever put together properly to be broken. But obviously the system is a tremendous challenge, and especially in getting behavioral health care or mental health care. But the positive side, I actually saw of this was seeing how people, when you put them in a room, including the physicians that really worked hard for this, but the hospital administrators, we were very fortunate to be at a university hospital where hospital administrators really worked hard to make this happen. But even the third-party payers, the insurance companies, when we got to talk to the people from there, there are real people behind them that want to help people. So I think, I was very encouraged by the fact that individuals want to make the system better, but the system, I'm not even sure I can say needs a major overhaul, because I'm never quite sure it was put together the right way to begin with. But clearly the mental health system in this country, but throughout the world, is not prepared for the need that's placed on it right now. It's a tremendous burden, and the cost of it is substantial. And we have to figure out a way of delivering all treatments more efficiently and effectively, or else we just can't afford to do this.
It's very so true. And again, just the weight of it and the impact and the sobering nature, as you both shared, but actually, especially as you shared your story. And I know you shared some suggestions in the piece as well, but I'm curious how, that came out in 2019. Have these conversations moved, and how have you all, both in your individual spheres and even collectively, tried to move things forward to, I don't know the right word, if it's not fixing the system, but to get to a place that's better? Because Ashley, as you mentioned, it's a matter of life and death in a lot of situations, to be completely frank. And how do we ensure and move forward to more likelihood of life?
Yeah. So, I'm really thankful for the relationship I have with Jerry, in part because I get to be in conversations like this, right? Where I get to share my story, both to help those who are suffering feel like they're not alone and a path forward, but also I think to speak to the gravity of the situation. And I don't think we as a society appreciate that, of how life-threatening depression can be, and how, immediately urgent and emergent it can be. And we definitely don't fund it the way we fund other illnesses of similar severity or threat. It was interesting in this process in 2016 when I was on my first medical leave. My brother was on his medical leave after having brain surgery he had cancer. And we would talk about how different our experiences were and, how both socially and who knew that we were on leave and who brought casseroles and those, that whole thing of just like, it is treated very differently. But there was a point at which I'm not at that point anymore. And I'm not comparing depression to those. I'm not saying what I have is the same thing what my brother had. The trajectories are less certain. There are all sorts of, major differences. But like, there was a point where like my life was in severe jeopardy if I didn't have treatment. And so I think really sharing that and getting that message out, I think to put some urgency behind it of like, one, we need access to treatment, and two, we need access to better treatments. Because what about those of us who, aren't responding to kind of what's already there? And I think the other thing, I comment on quite a few things in this article about, research and how can we make it more beneficial to participants who sign up. And I have some suggestions for that. And I know, the interventional psychiatry service has taken, some of those suggestions, but the funding and I think reimbursement for care. And like Jerry said, it's very expensive. I mean, I still receive free care, which like I have a lot of feelings about, really complicated feelings about, but definitely gratitude for sure, but lots of complicated feelings. And here I am, I told you I had some health issues these last 2 years. And, one of the medication or, one of the treatments I might take is going to be like, $10,000 a month, which is much more than my ketamine bill is, but my insurance is going to pay for it. Kind of without much question of like, once these things are proven and we have these labs to say this, you can get this treatment that's very expensive and like, but have access to it. Whereas like we have, I don't know how many years of data. I've probably had 130 ketamine treatments. And like, we have very good data that show that like when Ashely can get this treatment, she is pretty well and still can't make that case. So I don't think that necessarily even answered your question. I'm not sure I remember what it was, but
no, but it's still helpful. I mean, there's the context for all of it.
Yeah, I think Ashely highlights many of the biggest problems we face, but the issue of providing affordable, efficient, and effective behavioral health care is immense. I mean, it's huge. And I don't think it's possible to target it at one spot. It really is the whole system. We need to be able to have early recognition. We need to have access to treatment. We need to have what we call the appropriate level or step-based care. Because as we talked about, depression is a very heterogeneous illness. Not only heterogeneous, it's one that the evidence is pretty clear. If you can address it early, you could prevent later progression to more severe and treatment-resistant stages. And then obviously for the unfortunate people that don't have early responses, that we have access to these really cutting-edge treatments. And it's hard to do one of those in isolation. It really is. The demand is just so much greater than the supply of the system. It's just impossible for every person who needs to be seen by a behavioral health specialist to be seen. There's just not enough around, and especially for everybody to be seen by fully trained psychiatrists or fully, but there's appropriate levels of care that can be initiated. And the earlier you can do that, the less expensive or less costly those are. So it's a major overhaul of the system that needs to be done. I think we're getting there. And as I said, I'm trying to infuse a little optimism too, that I think people really care. And I think even people think the insurance companies, they're just, I can tell you when I talk to the individuals there, people do care. It's just, how do you make this work fiscally? It's not an easy solution, but it's something we need to do. And I think now more than ever, we're seeing that it's reached the crisis point, that especially for psychiatric disorders, especially for depression, the impact it's having on the country, the burden on the country, both economically, but even just personal pain is just not tolerable anymore.
Yeah, definitely agree with you. And although, people may feel like we're not giving a lot of answers, I think part of it is just the awareness too, because, for those of us, and I put myself tangentially in that category, but in the field, conversations that we've been having for a while, but as much of these conversations need to be expanded and enlarged and in scope so that the system can be changed, because just in small pockets, that's not going to do it, as you were alluding to as well. So I think it's really
I mean, these are issues that are nationwide in terms of reimbursement and in terms of how do you bring these novel treatments to actual clinical care. I like you, I grew up, my background's in physiology and biophysics. I'm a pretty basic scientist at heart. And I always had the idea that if we understood the basic physiology, we could develop good treatments. The rest is easy. Now, being in the field for 25, 26 years, I realized that the basic science is actually the easy part. It's the implementation science that's a lot more difficult, showing that these treatments are effective, determining who they're effective for, and then getting it, even once it crosses the goal line, how do you actually get it to patients? These are some real struggles.
Yeah.
I think the other thing I didn't mention, I'll be mad at myself if I don't bring up, but I've talked about treatments and access to treatments, better treatments, those things. That I think the other thing that I talk about in my article, and I try to talk about all the time, and if you sit down with me, we're going to have a long conversation about it, but is about also the importance of the relationship between a doctor and the patient, and how in the system that we have built, how constrained that becomes. And, really, I think the burden that the healthcare system places on doctors is tremendous, and on their time and the reimbursement, like all of these things. And in turn, how that impacts the relationship with the patients and the communication, and how, there are things that I remember that Jerry said to me while I was in the trial that I'm like, I will forever hold that in my mind, that I've had other physicians who say things. And I think really communicating, like being very clear to your patients, especially if they're not responding to treatments, or you're in a position where it's like, it's really hard to figure out. You can be honest about that, but to really communicate, like, I am not giving up on you, and I'm in this with you, and some of I have a team of psychiatrists, and some of them I get to hear them talk because I'm at the university, and so they're out there talking. I get to, and one of my physicians, he was giving a lecture, and someone, there's a mixed audience of like the public and activists and neuroscientists, all of us, and someone spoke up of like, what about someone who's tried 20 medications? Like, what do you say to them? And he said, no one has tried everything, and I will never give up on a patient. And I mean, I believed him 100%, not only because he's my doctor, but like, it is like, that is for sure where he's at, but like how much longer that can help someone hold on, and just give a little more hope, or like you're holding the hope for the person who can't hold it. Like that is very, very important. And sometimes there isn't anything to do. Sometimes there's just in that moment, like nothing that can be done. But I think acknowledging and sitting down with the person and their suffering and really saying like, I understand what it is I'm asking you to do. I understand by asking you to stay around what that means, because I'm listening to you. I'm feeling it. I'm believing you, rather than just like, this kind of, well, we'll get around to it next time, or, or I don't know what to do and sorry. But I think really being in it with the person, communicating that is medicine.
Yeah. At its heart, in its truest form. That's so powerful. And the fact that those
probably our most potent medicine too.
Yeah. Very, very true. I'm sure, we could, if we had more time, we can talk about the neuroscience of that and what that's doing to our brains and the interaction there. So
I would love to sit down another time, Nee, and go through that, because that would be a great topic.
Yeah. Well, I'm grateful to both of you. I mean, I feel like we talked through a lot of important topics, but then also just touched the surface in some ways too. There's so much there. So definitely, be happy to revisit in some shape or form as well. But to close out, I did want to just ask both of you, to kind of share what gives you hope in this work. And I know you both alluded to that a little bit as well. And then also if there are any resources that you want to share with listeners. Ashley, we'll be sure to actually put your piece on the website too, so people can access it pretty easily.
Thank you. Thanks.
But Jerry, maybe we'll start with you and then have Ashley wrap up.
So I do think for depression, that the advances that have been made in the past 20 years have been quite amazing. The neurobiology, I think, is decades ahead of the clinical care in our understanding of some of the basic neurobiological underpinnings of what we're talking about when we talk about depression. It's not a homogeneous illness. There's many different pathologies or ways that you can get there. And I think we're starting to make real strides in understanding that. And if you think about the availability of novel treatments, I mean, really up until the last few years, almost every medication that was available for depression was based on the monoaminergic hypothesis. This very hypothesis that was developed in the early 60s, suggesting that norepinephrine and serotonin, to some extent dopamine, the basic monoaminergic neurotransmitters, were the core of depression. The neuroscience, for 40 years, we've known that could not account for the basic pathology of depression, the pathophysiology and the treatment. But we've learned so much. Now, in the past 5 to 10 years, novel treatments have been approved by the FDA that do not target those systems in any way, such as S-ketamine, or a version of ketamine for depression, and another drug targeting the GABAergic system for depression, for postpartum depression, and many new drugs in the pipeline. So we've sort of broken out of that box that's constrained us for nearly 50 years and opened up a whole new vista of ways of developing treatments. But beyond that, we've also developed novel neurostimulation treatments, TMS treatments. For years, we've had ECT, but that was it. Now we're really trying to find ways to refine those treatments. And we've also broken out of the box of just accepting the fact that it takes weeks to months before somebody can benefit. Ashley can tell you, one day struggling with this feels like an eternity. I mean, when you tell somebody, well, you'll feel better, but you're going to probably feel worse before you feel better, and it may take 2 months before it's clinically noticeable. We've broken out of that. Now we know there are treatments that can make people feel better in a much shorter period of time. Yeah, we still have a long way to go to improve upon that, but I think the advances are quite real and tangible. And I think the next few decades will bring many more. And I think the next few years will actually help us refine what we do have.
Yeah, that's definitely encouraging. I appreciate you putting that perspective and giving that perspective for our listeners as well. Ashley, we're giving you the floor for the closing words.
Oh gosh.
No pressure.
No, I think conversations like this or your podcast, I've listened to almost every episode at this point. Wow. Those things give me hope. I think, we are having a more public dialogue than ever about these things, and are making some significant strides in our awareness, how we think about things, how we talk about things. I think the pandemic is definitely pushing our healthcare system, actually, as I think just push it way past the brink. And I think we're going to be forced to reconsider this system that we've built. And I'm hoping that, I think we're going to see a large mental health kind of fallout from this if we're not already seeing it. And what we build and imagine in the future will have to consider that, whether we choose to or not. It's going to be in our faces. So in some ways, I feel hopeful about that. I also think, nationally and internationally, along with the pandemic, there's, I think more awareness of racism and oppression. And these kind of things are challenging us to figure out, how do we cause harm? How do we help and how do we show up for each other in a way that I think is a really different, at least for me personally, is also it has a very different quality and a very different conversation. And I think as we learn to show up for each other better, I think both we can reduce depression from it happening to begin with, but then also, have more resources and supports to get people help. So yeah, that's where I'm at.
Really well said. And you put that in great context too. Again, this, we touched the tip of the iceberg, but we also covered a lot. And I think, just a level of honesty and sincerity that you both share too. I know that's going to be really important for a lot of folks, and also be curious about questions people have on this episode too. So, at some point we'll have to have a round two and continue the conversation, but definitely appreciate both of you being here. Hope you both have a good holiday. I know that can be challenging as well, but some time to relax, and just grateful again for where you all went, and just the investment that you're both making in so many different ways. So thanks so much for joining the Addy Hour podcast. Appreciate both of you.
Yeah, thanks so much for having me. I would love to come back if you have us. So.
Okay, excellent.
It was really my pleasure, Nee, and great seeing you again, Ashley.
Excellent.
Good seeing you.
Great to see both of you.